Very good morning to everyone present. I'll be presenting an interesting and unusual case who presented with steatotic liver disease on behalf of the Department of Pediatric Hepatology. So, starting with the case, this is Master K, a 10-month-old. He was born out of a term delivery, 3.2 kg birth weight. He had no adverse perinatal events. He is the firstborn child out of a non-consanguineous marriage. He presented initially to us at 10 months of age, and he was symptomatic since 5 months of age with intermittent episodes of diarrhea, which did not cause significant dehydration for the child to get admitted. And the parents also noticed generalized abdominal distension progressively from 5 months of age. At presentation to ILBS, on detailed history taking, there was no history of jaundice, there was no history of pallor or requiring any blood transfusions, there was no history of skin bleeds, there was no history of a night awakening or symptoms suggestive of early morning or late night hypoglycemia. On anthropometric examination, the child had slightly lower length for age, but it did not qualify for stunting, and the weight for length was appropriate. Coming to the systemic abdominal and systemic. The child had no abnormality on his hemogram. Liver function test was suggestive of a deranged liver enzymes in the form of elevated AST, ALT. Synthetic function was preserved with albumin being 4.2 and INR being normal. This led us in the direction of a metabolic liver disease.
Sorry, can you go back to the neurological examination?
Yes, sir. That was also appropriate for age. He was gaining milestones for his age and he had started.
No history of seizures?
No history of seizures, sir.
What was the liver, firm or?
The liver was soft, firm, sir, soft to firm.
You can't have soft livers that big.
Yes, it was firm, sir.
Firm, nodular, non-nodular?
Not nodular, sir. Firm but not nodular.
Okay, good.
Margins were well defined, ma'am. So the initial metabolic screen showed a fasting blood sugar of 49, which was at 4 hours of fasting. Lactates were normal, ammonia was normal, urinary non-glucose reducing substances were negative. The child also had a deranged lipid profile. Outside triglycerides were in the range of 500 and our baseline value was 115 and also had a low HDL value. His fibroscan showed an LSM of 35. On ultrasound evaluation, the child was found to have grade 2 fatty liver. So coming to the differential diagnosis, we now had a child who's presented to us with steatotic liver disease. So the first thing that we should look for in this child are whether there are any red flags and that whether the child needs urgent evaluation. So what would be the red flags in a pediatric patient with steatotic liver disease? So any patient who has an early onset of steatosis under 8 years of age, who has developmental delay, any synthetic dysfunction, low BMI associated with steatosis in the liver, presence of splenomegaly should be evaluated urgently. So our child had an early presentation. He had an appropriate BMI for his age and there was presence of splenomegaly. So we evaluated on the lines of a metabolic liver disease. So this is a basic outline for how the evaluation algorithm would be based. So we now have a child with organomegaly who has a suspected metabolic liver disease.
Sanjeevni, we confuse matters for adult hepatologists when we say metabolic liver disease. Say we were now suspecting an inborn error of metabolism.
Yes, ma'am. So now we have a child with organomegaly with a suspected inborn error of metabolism. So if the child has a predominant hepatomegaly, if the child has hypoglycemia with or without elevated lactate, if that is present, we would then go ahead with urinary non-glucose reducing substances, which would check for the presence of fructose. If that is positive, we would suspect hereditary fructose intolerance. If that is negative in the presence of organomegaly with hypoglycemia, our possible differential diagnosis would be along the lines of glycogen storage disorders, of which according to this age of presentation, GST 1 and 3 would be the most common. If there is no hypoglycemia and the presentation is predominantly of hepatomegaly, the differentials could be Wilson disease or cholesterol ester storage disease, which could present just with elevated transaminases, hepatomegaly, and a fatty liver. If the child has hepatosplenomegaly with predominant splenomegaly, the possibility of infiltrative liver disorders due to other etiology with bone marrow involvement is more common, and bone marrow aspiration biopsy would be done. So this was not suspected in our child because he did not have the hepatomegaly was predominant. He had fatty liver on his ultrasound, and there was no presence of any cytopenias. Yes, ma'am. If there is hereditary fructose intolerance, that would be postprandial, and in GST, the hypoglycemia would be fasting. So now we had a differential diagnosis of GST type 1, for which our child had suggestive facies. He had hypoglycemia. All of these differentials would present with hepatomegaly and deranged liver enzymes. So in favor of GST, we also have hypertriglyceridemia in this child, but we did not have lactic acidosis, which is common. And we also had the presence of splenomegaly, which was uncommon.
And ascites.
Yes, sir.
The patient also has decompensation in a form.
He did not have ascites at
You said
presentation.
this ascites?
No, sir.
For months, 5 months onward to 10 months.
Yes, sir. He just had abdominal distension.
But then you don't use the word distension. You use the word fullness.
Yes. He did not have ascites, sir.
Okay, I thought it was ascites. Okay.
Coming to hereditary fructose intolerance, the child had hypoglycemia and episodes of diarrhea, which could be fitting with hereditary fructose intolerance, and splenomegaly could also be explained. But it is not common to have elevated triglyceride levels. Coming to cholesterol ester storage disorder, diarrhea is a common presentation in up to 20 to 25% of these patients, and they can have hypertriglyceridemia as well as low HDL, which was also seen in this child. But these patients usually have elevated cholesterol levels as well, which was not present in our patient. So he was evaluated along the lines of these disorders. So a liver biopsy had been done at an outside center that was reviewed. Liver biopsy showed acinar disarray. There was marked diffuse macrovesicular steatosis. The hepatocytes were enlarged with prominent membranes, and there was presence of bridging fibrosis. Further, we also for evaluation of cholesterol ester storage disorder, we did lysosomal acid lipase enzyme levels, which were normal, and the child was presumed to be started. The child was treated on the lines of GST and HFI and started on a cornstarch-based diet and a fructose-free diet. On further evaluation along the line, the child was admitted for re-evaluation at 2 years of age. At this point, he had persistent organomegaly. Now there was presence of facial telangiectasia and palmar erythema. We admitted the child and did a fructose challenge, which came out to be negative. Upper GI screening was also done, which did not reveal any varices. And now he had a new sibling, who also had similar complaints in the form of organomegaly. Over the course of his follow-up, it was noted that he had persistently elevated cholesterol levels and significantly raised triglyceride levels on follow-up in the range of 150 and going up to 520. So on his genetic evaluation, the defect found was GPD1 deficiency, which was a missense mutation in exon 5, which is labeled as an variant of uncertain significance in this case. So now coming to this entity, which is previously described as transient infantile hypertriglyceridemia, which we will see may not be the correct terminology for it, because it has now been seen to have persistent effects and not really transient as it was previously described. So this entity usually does not have hypoglycemia, which was the uncommon finding in our child. Diarrhea is also not known, but it can have hepatomegaly, splenomegaly, persistent hypertriglyceridemia, hypercholesterolemia, elevated liver enzymes, fatty liver, and a percentage of patients can also have cirrhosis or advanced fibrosis on their biopsies. So what is this defect? It is a rare autosomal recessive metabolic disorder, usually presents in infancy with severe hypertriglyceridemia and hepatomegaly, and previously described as benign and self-limiting, but there is new literature which suggests otherwise. So coming to the pathophysiology of this disease, the glycerol 3-phosphate shuttle lies at the inner mitochondrial membrane. It is similar to the malate aspartate shuttle and consists of two enzymes, the GPD1 enzyme, which is cytosolic and NADH dependent, and it catalyzes the conversion of dihydroxyacetone phosphate to glycerol 3-phosphate. And in the process, NADH is changed to NAD plus and electron transfer is done towards the inner mitochondrial membrane. On the other side, we have the GPD2 enzyme, which catalyzes the opposite reaction, and it is FAD dependent and lies along the inner mitochondrial membrane. The main physiological process of this GPD shuttle is to transfer electrons via this reduction to the electron transport chain where it is further used. So this shuttle thus links three major processes: the glucose metabolism, because dihydroxyacetone phosphate is an intermediate in the glucose metabolism; bioenergetics, because it is providing reducing substances to the electron transport chain; and lipid metabolism, because this dihydroxyacetone phosphate can further form acyl DHAPs. So coming to the further pathophysiology, though it is not well described how it is causing all the effects of this disorder, but it is postulated that the lipid accumulation can occur, one, via the dihydroxyacetone phosphate collection, which will further go into formation of alkyl DHAPs and acyl DHAPs. The other postulated mechanism is that since this reaction is reversible, there is also accumulation of glycerol 3-phosphate, and this glycerol 3-phosphate can cause hepatic accumulation of triglycerides. So the initial cases were described in 2012. So it is a relatively recently described disorder. So this was the first case series. In this case series, they described 12 distinct patients who were all of Israeli descent, but they were scattered across the world, and they were all born out of consanguineous marriages. So we see these 12 index patients. As we can see, all of them had their presentation during infancy. Most of them had hepatomegaly, which was the consistent finding. Some patients had splenomegaly as well. And on long-term follow-up, we can see that their triglyceride levels, which were initially elevated up to 6,000, ranging from 200 to 6,000, mostly improved. And their liver enzymes also mostly improved on the last follow-up. But there were further reports which showed that this was not always the case. This case series from 2016 showed a varied presentation of the similar deficiency, with one subject having recurrent episodes of fasting hypoglycemia, hepatomegaly, hypertriglyceridemia, similar to our patient, with second having severe liver disease, also having cholestasis with kidney involvement, which is rarely described previously, and the third patient having persistent hypertriglyceridemia even up to the age of 30 years. So this is a recent publication from the Indian subcontinent from the SGPGI group, where they have described 5 patients from their experience. These patients had a median age at presentation of 6 months. Hepatomegaly was a consistent finding. Most of the patients had splenomegaly, one had hypoglycemia, and one had consanguinity. And all the patients had consistently steatosis on their ultrasound examination. Lab evaluation showed elevated triglyceride levels going up to 1,000 milligram per deciliter, and ALT levels varying from 2 times to 5 times upper limit of normal, with mostly normal cholesterol levels. They had biopsies available in 3 patients where total fibrosis were the maximum grade of fibrosis. And on a median follow-up of 12 months, they noticed that the triglyceride levels normalized in all patients. One patient had a normal ALT, but all of them continued to have progressive organomegaly. So this is our experience. We have 5 documented cases with genetically proven disease and 2 patients who are awaiting genetic confirmation. So our patients had presentations varying from 2 months to 12 months of age. All had infantile presentation. At presentation, some of our patients had growth failure, whereas the others were preserved for their age. The predominant presentation was in the form of organomegaly, with one patient having symptoms suggestive of hypoglycemia in the form of early morning irritability, and two patients having recurrent diarrhea. Coming to the lab evaluation of our patients, they had more or less normal hemograms, with one patient having thrombocytopenia. Liver function tests predominantly showed elevated liver enzymes from 2 to 5 times upper limit of normal. Synthetic functions were preserved in all these patients, and the lipid profile showed a deranged profile of triglycerides, which were consistently elevated, and cholesterol levels were more or less normal. Apart from one patient, which was the index case having low HDL, levels were normal in rest of the patient, were more or less normal in rest of the patients. Metabolic screen was done in all these patients, and it was within normal limits for all these patients. Coming to the histopathology varied in our patients. Most of the patients had severe diffuse macrovesicular steatosis of large and small droplet type, with some patients having no increase in fibrosis and other patients having up to bridging fibrosis.
Do you have a high power of these cells?
No, sir.
What about the nuclear vacuolation?
Nuclear vacuolation was there in few of the cases, sir.
It is paramount importance.
Yes, sir.
You know, nuclear is a pathology colleague here, Archana Chagan. Because that's glycogen. It's classical nuclear glycogen deposits. Okay, go ahead.
So on imaging and histopathology, ultrasound showed consistent hepatomegaly and fatty liver in all these patients, and liver histology, as has been described, with the presence of advanced fibrosis present in at least 3 out of 5 of our patients, thus refuting the previous cases, which initially reported only early or no fibrosis, and LSM values varied across these patients significantly. So these patients have been described from 2012. Multiple case series have been written. Around 8 patients have been reported from the Indian subcontinent. Most of these patients had their presentation in infancy, with the predominant features being hepatomegaly and fatty liver, along with dyslipidemia. Few patients in case series have had other features such as failure to thrive, short stature, insulin resistance, and kidney involvement in one of the case series. So 2 of these cases have previously been reported from our center as well. So the consistent phenotype that we have seen now is that of hypertriglyceridemia with hepatomegaly and elevated liver enzymes in the presence of fatty liver with or without hepatic fibrosis. So when should we suspect this disorder? In an infant with severe hypertriglyceridemia where other causes have been ruled out, in the presence of hepatomegaly, usually without hypoglycemia, normal lactates and ammonia, and a relatively well-looking child. And the importance would be that it mimics other metabolic liver diseases such as glycogen storage disorder, which may prompt unnecessary investigations. High triglycerides can cause anxiety, and if we have a genetic diagnosis, we can provide reassurance and continue to follow up these patients. There are some postulations as to why this condition is transient, because there is supposed to be maturation of alternate metabolic pathways which would handle this excessive byproduct formation and developmental adaptation and the improved hepatic clearance with age, but the definitive mechanism is not yet described. So the diagnostic approach in these patients would be to exclude secondary causes of hypertriglyceridemia, which would be related to any intake of drugs or any secondary lipid-related lipid-related disorders, lipid profiles and liver enzymes, and finally a genetic panel, which would include whole exome sequencing and further family screening. On long-term follow-up, natural history is still unclear. Prognosis remains mostly favorable even when the patients have early liver fibrosis. Up to a maximum follow-up of 31 years of age, none of these patients had developed coronary heart disease or pancreatitis despite elevated triglyceride levels. None has required liver transplantation, and all the patients have been described to have normal neurodevelopment. Coming to the biochemical parameters, in a follow-up series with up to 3 years of follow-up, triglyceride levels normalized in 1/3 of them. Transaminases also normalized in 1/3, and hepatomegaly regressed in around 1/3 of patients. So the management is mostly supportive. There are no dietary guidelines, but on extrapolation from pediatric guidelines for hypertriglyceridemia, a low-fat diet and which is containing low saturated fats and trans fats, and MCT-rich diet, which could be the predominant source of fat, may help reduce the triglyceride levels. There is a theoretical risk of secondary pancreatitis if the triglyceride levels remain more than 500 milligram per deciliter, and fibrates can be thus considered in consultation with endocrinologist and close follow-up of these patients. Coming to the monitoring, these patients require regular monitoring of their growth and development, organomegaly, the liver function, lipid profile, and routine imaging, because it is not known whether these conditions can lead to the formation of any precancerous or cancerous lesions, though none of those have been described except for one case which showed a possible adenoma. It is important to vaccinate them against the preventable hepatitis A and hepatitis B, and caution should be advised with the use of hepatotoxic drugs or CAM, which may complicate the illness, and genetic counseling. So it is still debatable whether these patients should be regularly evaluated for coronary artery disease or pancreatitis. So the key take-home messages from this case and our experience with this disorder is that it should be considered in a case of unexplained elevated
Can you
liver.
give your final diagnosis before key? What is your final diagnosis?
The final diagnosis is syndromic diagnosis was
No, final diagnosis in the patient. What's your diagnosis?
GPD1 enzyme deficiency causing hepatomegaly.
No, that's the technical part of it. What is your diagnosis?
Some metabolic liver disease due to GPD1 deficiency.
Because this is not a diagnosis. Patient wants a diagnosis. So what is it?
So it would be a metabolic liver disease involved with the abnormal lipid handling. That's what we would.
Because you are switching on from glycogen to triglycerides. So how do you make your clinical diagnosis? On a clinical prescription, what will you write?
Suspected inborn error of lipid metabolism in a liver disease with suspect.
So you will write inherited disorder of metabolism or metabolic liver disease. What will you write?
So we usually label all of these as metabolic liver disease, but it is an inborn error of metabolism, which with a defect in in an enzyme which is causing abnormal lipid handling, because the suspected the substance that is being accumulated is likely triglycerides in these patients.
Yeah.
No, sir.
Yeah. So have you made a table where GSD1 vis-a-vis hypertriglyceridemia? I know you have shown, but if you have these two in your top priority, what is the difference between these two alone?
Yes, sir, I'll explain this table. So GSD1 and GSD3 predominantly they will present.
No, only GSD1.
GSD1 will have significant hypoglycemia, sir. Early onset of hypoglycemia and predominantly hepatomegaly. That is the most important presentation, and they will also have significant hyperlactatemia, hyperuricemia.
What about the eye? What happens to the eye in GSD1?
Sir,
anything in the eye like cataracts and others?
No, sir.
And in hypertriglyceridemia?
That has not been described, sir. None of the end organ effects have been described.
Splenomegaly?
Yes, sir. GSD1 will usually not have splenomegaly.
Simple large liver?
Yes, sir. Only soft, large liver will be
And
there.
triglyceride?
And triglycerides may be elevated, sir.
No, no, in the triglyceridemia type of,
They have been reported to have splenomegaly. In the SGPGI series as well, 4 out of 5 patients had splenomegaly. In our
Well,
experience,
is it a variant of Niemann-Pick or so, or what?
so Niemann-Pick usually is will have one neonatal cholestasis may be part of the presentation, and they will. It is a storage disorder, and it will cause lipid storage disorder.
What are lipid storage?
But
This
it will
one your
have-
triglyceride?
Yes, sir. It will have cholestasis, and it will also have neurological involvement and other
That is true.
multisystemic
They are
involvement.
not type 2, type 1 may have more.
So type
Okay,
3 usually has an
Type-
infantile presentation with cholestasis and neurological involvement.
go ahead. Okay.
I think, sir, cholestasis is a very
Type C.
important feature of Niemann-Pick. So,
Yes, ma'am. One or two patients had, ma'am. We don't know. 2 patients had elevated GGT. Not sure of the cause of the elevated GGT in these patients. We're done.
Very educative case, we do see, but what was the surface of the liver?
Surface was smooth, sir. He's still on.
And there was no fibrosis,
So there was bridging fibrosis on
so
biopsy.
F3 fibrosis.
Yes, sir. He
Okay.
continues to have initial LSM was 35, that has decreased to 18, but he continues to have persistent organomegaly even on follow-up. And he has been started on
Sorry?
fibrates on the last follow-up.
And the cardiac evaluation is all right, the heart, despite this high TG.
We have done one echo, sir. Apart from that, we have not
Maybe
evaluated.
MRI of the heart or something to see
That
what
is-
it is
yes,
like.
we have not done. It has not been described in literature, but we may consider
You will
doing.
describe literature, you don't have to say.
We have not done. We have just done an echo, sir.
Okay, Rajiv, any comment?
So in fact, the SIB of this index patient, so he had significant portal hypertension also. So he had varices, but now in the last endoscopy, the varices also, because this disorder, it was initially labeled as transient. So we also think that possibly these children are actually coming out of their disease. And we, for three out of these 5 children, we actually suspected glycogen storage disorder, and for initial few years we treated like that, because in the absence of the genetic diagnosis at that time we could not do exome sequencing, and subsequently when we got the exome sequencing reports and then we compiled these cases, then we got to know that this is actually a transient disorder, glycerol phosphate dehydrogenase deficiency.
I hope you are keeping the blood and the tissue in the biobank for all these inherited disorders. These are rare, very educative. Do you have the facial photograph of the child by any chance?
I
You
have.
said these are typical faces.
He doesn't have it now, sir. When he presented in infancy, he was suspected to have a doll-like faces. He does not have
That's fine.
typical faces now, sir. But I have his old photograph.
Dr. Call, any comments?
Is it fat globules or the glycogen in the liver? What you show on microscopy? Glycogen, it's lipids only.
Mm.
That's why actually the glycogen storage disorder was not a possibility, but we treated in the initial few years like that with cornstarch diet, and there was some partial response. It may be just on its own. There was the partial response which happened on its own.
Thank you.
Okay, thank you, very good. Any other comments, please? We start new year with a very, very interesting, educative, unknown entity. Very good. Is there another case presentation? Oh. Our residents would have popped up anytime. They're so bright.
So vibrant faculty.
Yeah. I did not know that. Anyway, a big round of applause to pediatric hepatology and the Dr. Call. I could, yeah, all right. And we hope that the new year we have a better resolve for academics, a better resolve for learning together. And I wish everyone on behalf of ILBS a very happy new year, and I hope you all join for lunch today. Thank you.